Let us now move on to the next session for the day. In today's era of healthcare, the quest for personalized medicine has reached the forefront of neurological care. As we navigate the complexities of various neurological disorders, precision neurology emerges as a beacon of hope, offering tailored approaches to diagnosis and treatment. By harnessing breakthroughs in genomic sequencing, neuroimaging, and biomarker analysis, we stand on the cusp of a paradigm shift in how we understand and address these conditions. And with this, let me introduce you all to the topic of this panel: Advancing Precision Neurology, Optimizing Diagnosis and Treatment Through Personalized Approaches. Now I'd like to welcome our panelists to join us on stage. Please welcome them with a huge round of applause. Dr. Manish Mahajan, Senior Consultant Neurology and Head Neuroimmunology, Artemis Hospital. Dr. Kunal Behrani, Director Neurology, Fortis Hospital. Dr. Anushka Amlani, Team Voice of Healthcare. Now I request Dr. Amlani to please take over this session from here.
Thank you, Dr. Tarini. Good afternoon, everyone. I'm Dr. Anushka Amlani, and on behalf of Voice of Healthcare, I thank you for your presence for this panel discussion, where our experts, Dr. Kunal and Dr. Manish, will be discussing about advancing precision neurology, optimizing diagnosis and treatment through personalized approaches. My first question is to Dr. Manish. So can you please shed some light on the role precision medicine plays in neurology in general?
Thank you. First of all, I would like to thank the organizers for considering me as the panelist, one of the panelists. And I think that's a great concept. And thank you for the question. I think this is something which has been always there. If we talk about neurology, it covers almost 80% of the disorders which are covered in the International Classification of Diseases. So there is a huge set. It's not one disorder that comes under neurology. So what we commonly face in our OPD and IPD practice is something which everybody knows, epilepsy. But again, it's not a single disorder. So if we say epilepsy, there are number of varieties of epilepsy. There are number of, and it's a huge spectrum, starting from even from the newborn to the last, or octogenarian you can have, or octogenarian you can have someone who can develop epilepsy. So obviously something which can be diagnosed, and the way you diagnose and the type of epilepsy you diagnose in a newborn would be definitely different. The reasons would be different. So that is something which how the things have evolved. So earlier we used to have one drug which used to be called as anti-epileptic drug, or then the things and the number of drugs evolved. But slowly and slowly we understood that it's not that the drug can be less effective in particular type of epilepsies. It can be rather detrimental. It can enhance or it can aggravate the epilepsy of few types. Like you can't give phenobarbital, or you can't give sodium channel blockers to people who have myoclonic epilepsy. That can aggravate such type of epilepsies. So when you understand the disease better, disorders better, you tend to understand their mechanisms, their treatment, which are not only effective, but they are not detrimental to the particular diagnosis. So here, when you precisely diagnose, you precisely treat the patient. So that means that's the first step. And I think as a neurologist, we are the closest. Dr. Kunal will agree with me that the first step, and it's the most important step in the management of a patient with neurological disorder, that is the diagnosis. So once you have diagnosed, treatment could be straightforward. And there are a number of other disorders where I think precision neurology is now being catered. I head neuroimmunology, so I can talk about immunology. Earlier, everything would be under the ambit of CNS demyelination. Now, multiple sclerosis. Then even there were few variants which were called as opticospinal multiple sclerosis. And Western world would differentiate Eastern that they have more commonly opticospinal multiple sclerosis. Now then, the slowly, with the advent of and the evolution of molecular biology, we came to understand that these are the patients, subset of the patients who have different type of antibodies circulating in their bodies, what we call as now the anti-aquaporin 4 antibodies. So that is something they were called as a totally, and it's not far. The first diagnostic criteria for this entity which I am talking about, which is now called as neuromyelitis optica, were defined in 2015. So how far it is? We are less than 10 years now. So maybe when me and Dr. Kunal were doing our residencies, we used to see these patients, we used to see these, but they were better called as an opticospinal MS rather than NMO. Then first diagnosis came in 2015, criteria for this, and that is now evolving. So that is how the precision, and mind you, some of the drugs which are being currently also used for multiple sclerosis, they aggravate the cases for neuromyelitis optica. So that is the role of precision medicine in neurology. That is, you not only help the patient better by making and giving more effective treatment, you avoid such complications of the treatment as well. Thank you.
Thank you so much for your insights, sir. Moving ahead, my next question is to Dr. Kunal. So these days, one of the most common neurological disorders we see is epilepsy. Can you please elaborate on the role of genetic testing in guiding personalized treatment plans for individuals with epilepsy, including the selection of appropriate anti-epileptic drugs and potential surgical interventions?
Thank you. First of all, to start with, I thank you, organizers, VH Healthcare, to set such a nice and platform. So, as you rightly said, epilepsy is one of the very common neurological disorder which we see. So, if we talk about the numbers, so we say 1 out of 26 people will suffer from epilepsy in their lifetime. So that is, you can see it's a huge number. So now the question comes, what's the role of precision medicine? So as Dr. Manish started, so whenever we diagnose epilepsy, so it's a disease which not only impact to the patient but also to the caregivers, because the treatment is long. We have to take the financial, we have to take the psychological aspect, and there are many aspects we have to take care of in treating such epilepsy patients. So how now comes the role of precision medicine? So when we see the etiology of epilepsy, what is the causes of epilepsy? So there are many causes which have been described. It starts with perinatal insult, some structural causes, developmental malformations. These are very common in newborns. If we now grow, like it could be secondary to some CNS infections, could be secondary to strokes, which we commonly see a cause of epilepsy in elderly age group. But at the same time, many patients where we don't find the reasons of these type of causes of this epilepsy, there comes the role of genetic. So we call it is a genetic cause of epilepsy. So per se, genetics and epilepsy is very closely linked. Why I'm saying so? Because good chunk of patients where we don't find the reason of such epilepsy, there is the genes which are responsible for this epilepsy, and we are say that is a genetic cause of epilepsy. So to diagnose such patients for genetic causes, now comes the role of these precision. So this precision medicine not only helps to diagnose such subset of patients, but also to treat such subset of patients. Why I'm saying so? So first of all, like we see nowadays, there are many modalities to diagnose such genetic causes of epilepsy. Like we have a whole exome sequencing, whole genomic sequencing, which nowadays are available. Initially, when we were when we were in the residency days, we never heard of these genomic exomic sequencing. But now it is very freely available, and they are not very they are cost effective also. Why I'm saying? Because when we diagnose such genetic causes of epilepsy, it not only helps to diagnose, but also it helps to tailor the treatment plan, because there are certain anti-epileptic drugs now which can be tailored according to cause of epilepsy. Which a simple example I'm telling you, like we have some genetic epilepsies, like we say it's a Dravet syndrome, Lennox-Gastaut syndrome. These are some common genetic epilepsies where we treat with certain genetic drugs, which are targeted, which are given in certain epilepsies only. So there comes the role of precision medicine to diagnose such epileptic patients. And also at the same time, whenever we diagnose such genetic causes of epilepsy, it not only helps to diagnose, but also for prognostication. So many patients comes to ask whether, like if I'm suffering from epilepsy, if I have a family history of epilepsy, whether my second generation, coming generation will be suffering from epilepsy or not. So to answer such questions, there is always a need of such modalities which are available nowadays. So these modalities where we can diagnose, where we can tailor the treatment, not only helps to diagnose, but also in future prognostication also.
Thank you so much, sir. My next question is to Dr. Manish. So, what are some of the primary neurological disorders where genetic testing plays a significant role in diagnosis and management?
I think that's a very wonderful question. Part of it has been already answered by Dr. Kunal. Uh, Apart from epilepsy, we do have role of genetics in many degenerative disorders like spinocerebellar ataxia, which most of us see on a very routine. And we have few type of genetic ataxias which is very common in the Agrawal communities, and especially that too very common in the northern part of the country. So whenever someone with tremors come to my OPD, and the first question I ask, anybody else has got a history of tremors in your family? So they commonly, and I read the surname, and they belong to the Agrawal community, and the answer is yes, and they tell. So very common cause of another cause of genetic tremors is essential tremors, where you in 50% of the cases you can have a family history. Then I let them know that you need not do the genetics for the essential tremors. You just need to do it for the SCAR panel, and most likely we are looking for SCAR 12. That is something which we are looking for. And many of the times, and most of the times I would say that we are true. It's SCAR 12. So that's what's the role of history. Mind you, the role of genetics is secondary still. In neurology, we have history, and history. That actually makes the diagnosis. So how the things started, how the things evolved, what is the family history, as Dr. Kunal also mentioned, what's the consanguinity of the patients, especially we do get patients from the Middle East, or we get from the ethnicity where consanguinity is very common. So chances of getting an autosomal recessive disorder, they increase substantially when the parents are consanguineous. So you need to tend to have low threshold. And we do come across many movement disorders like Wilson's disease. That's a very common cause of pediatric cause of many types of movement disorder. It can present as regression of your milestones. It can cause neuropsychiatric manifestation. It can cause dystonias. So and it's a treatable neurological disorder. So it's not that all genetic disorders, they tend to you just label the people and then leave them like that. Now, many of the gene disorders, they are being treated by the genetic therapies. So we have now treatment for Fabry's disease. So that is a common problem, and it presents like neuropathy, painful neuropathy. And it's a disease which basically we have seen people, and it's being supported by, there is a patient support programs by Sanofi, where they are providing that drug, and we have government panels where patients are covered for. Earlier we were not able to. So the role of genetics is that you diagnose, you help that person. Earlier we just diagnosed it and we couldn't do anything. Now we diagnose, we offer them treatment, because now genetic therapies, either in the form of gene therapies or enzyme replacement therapies, we can help them out. And as I told, Wilson's, ultimately it's a metabolic defect that is there in the Wilson's. So you treat that and you prevent the complications from happening. So not only spinocerebellar ataxias, Wilson's, there is a role of genetics in stroke. So whenever some stroke in young comes, we find out whether there is a problem with the homocysteine metabolism. So that is where you hit hard. You prognosticate. So it's diagnosis, it's treatment, it's prognostication. That means alone aspirin will not work for this person. You have to have something else. Even higher doses of folic acid has to be given. You have to contribute. So, and inborn errors of metabolism. leading to many types of white matter changes in the brain. So all these things, they are basically linked, and I already told, the list is long, since 80% of the disorders are being covered by neurology. Nerve, muscles, the axis runs from not only brain, it starts with the optic nerve for us, brain, spinal cord, then the dementia. There is a role for genetics, because you have people who have early onset dementia. Then there are a number of nerve disorders. We have number of muscle disorders, where now the role of genetics has increased. Earlier it was muscle disorders used to be diagnosed only with muscle biopsy. Now they have been replaced by whole exome sequencing, or by specific disorders like sarcoglycanopathies or limb girdle muscular dystrophies. Now we no longer need muscle biopsy for that. You rather advise a genetic test for that and prognosticate accordingly. So all these disorders, they come under the prerogative of genetic disorders, genetic neurological disorders. But what we are now happy about is that we have treatment options available for these people, and I think that's the major reason why we need more such diagnosis, more such precision neurology, so that we can cater to the management. So always when I counsel my patients for a genetic analysis, there are two aspects to it. That early diagnosis will never always translate into better management. You need to remember that only we offer a genetic analysis when we can offer you something. It's not for labeling only. And secondly, another important aspect we as clinicians should always remember about ordering any genetic test is genetic counseling. Because just harboring a gene, the way Dr. Kunal said, that somebody in the family has a problem, the other sibling comes over, or the children come over, that should I go for genetic testing also? Do I harbor the gene? Do I have that? So the simple answer is, please be clear. If you harbor the gene, it's not sure. There is something called as epigenetics. So there is not sure that you will develop the disease always, but you will be burdened with that, and you will be suffering with a mental block that you have this now gene, and you are going to be affected in the future. And secondly, it can have financial implications, because now with people knowing that what is their genome like, this can have implications for your insurance. So you need to remember that just knowing your genome may not always help you. So all these aspects, it's not a simple scribbling on your piece of paper in the OPD. It's always a counseling, and it goes a long way. And I think all of the genetic centers which offer genetics testing, they do have counselors, and they do counsel their patients before they perform the tests. Thank you.
Thank you so much, sir. My next question is to Dr. Kunal.
So obviously, stroke is a complex. These are called as complex disorders. The most importantly, as of now, also they remain as a lifestyle disorders. I don't call them as genetic disorders, because see, we share a lot of genetics with our parents and the previous generation, but we are at much higher risk because of the lifestyle. Especially, I told you there is stroke in young. That means if the stroke is happening in a person who is not in his 60s, it's in the second or the third decade, I get a patient with stroke. Then after ruling out any structural heart disease where he or she can have a cardioembolic stroke, I look for, and I have ruled out the conventional risk factors. The lipids are normal, he's a non-smoker, he doesn't have atrial fibrillation, he doesn't have cardiac valvular heart disease or rheumatic heart disease in the background. Then there is no conventional risk factor. So then one should be looking for either vasculitis or other risk factor, genetic risk factors for stroke. And if there is a history of headache in that person, because there is a disorder called as CADASIL, where you can have migraines like headaches and you can have stroke-like presentations. So all these things, it's again, I told you, it's history. So you go back to your history. That what is the history? Is there any history of headaches? Or there is history of young strokes in the family also? So all of this which matters. It's not a routine thing that you order even in stroke in young. You do the conventional risk factor evaluation first.
So what can we take a precautionary measure to stop the stroke in the family for the general awareness? Because nowadays only believe on the blood report.
So it's common for all the cardiovascular risk factors.
Okay,
It's
so
through
how
lifestyle
frequently
modification.
we have to go for this test for the parents and
No need to go for genetic testing for.
no, I'm
for
not
the
talking about the genetic test. I am talking about the general test.
Yeah, so the conventional risk factors are known to all of us, that it's the smoking, it's the it's a heavy consumption of alcohol, then hypertension, diabetes, dyslipidemia, then hyperhomocystinemia, which is again sometimes caused because of the B12 deficiency, hypothyroidism, and you can have now something which we call as obstructive sleep apnea. And all of these what come under the ambit of metabolic syndrome. Obesity is the most common cause for everything. So reduce your salt intake, control your diabetes, control your lipids, control your homocysteine levels, quit smoking, have alcohol in moderation only.
Okay,
and
one more question.
Go for regular health checkups.
Okay, one more question. In my known too, I met the
Ma'am, no personal questions. I would like that this panel discussion. I am open to every question, but this will go long.
Okay.
I have no problem. I can answer you the whole day.
Thank you so much, Noosh.
Yeah, so no personal questions in the panels, please.
Thank you so much. My next question is to Dr. Kunal. Sir, what are some of the recent breakthroughs in precision medicine for neurodegenerative disorders? And how is AI being integrated into the evaluation of CT reports for stroke diagnosis?
So, to start with, you will be surprised to know, like right now, neurodegenerative disorders, somewhere the numbers are in 35 to 40 millions worldwide. But now the studies are there, reports saying by 2050, in next 25 years, these numbers will be 3 to 4 times. So somewhere around 115 to 120 million. So the reason of increasing these numbers of neurodegenerative disorders because of better healthcare. The aging population, the elderly will be more in numbers. So definitely this will be second most common cause of death and disability in coming days, maybe in few 1 to 2 decades more. Now, to start with the role of precision neurology, the neurodegenerative disorders comprise of many spectrum of diseases, of which the most common which we see in our practice is Alzheimer's. I'm sure you must all be have heard of Alzheimer's disease. So Alzheimer's, many of say many of us know, like if any of us suffers from memory problem, dementia problem, one is suffering from Alzheimer's. But this is not true. Alzheimer's per se, it covers somewhere around 70 to 80% cause of dementia, that is for sure, but there are other causes of dementia also. So, but what is more important is Alzheimer's disease per se is very heterogeneous disease. So every patient doesn't show a common symptom. Yes, most common symptoms starts with definitely with forgetfulness, memory problems, but definitely there are much bigger umbrella in Alzheimer's, not only the forgetfulness. So where comes the role of precision neurology? So now, if I talk about few years back, we used to diagnose Alzheimer's based on clinical symptoms. We used to take the history, we used to do certain logistics tests, then we diagnose a patient with Alzheimer's. But nowadays, there are upcoming biomarkers, whether they're biomarkers which we can see in the blood, where we can get these biomarkers in the CSF. To name some biomarkers, like their amyloid biomarkers, tau protein is there. So these biomarkers help us to diagnose Alzheimer's at a very early stage. Because if we depend on the clinical symptoms only, so usually it takes 3 to 4 years to diagnose Alzheimer's based on clinical symptoms only. So to diagnose Alzheimer's at a relatively early stage, we now use these biomarkers. So as I said, there are biomarkers in serum, there are biomarkers in CSF, which we call the spinal fluid. There are certain radiological biomarkers, like there are now PET scans, which we focus on the amyloid deposition in the brain. So these precision diagnostic modalities are there to diagnose such neurodegenerative disorder at an early stage. So why it is important? So till date, we used to target these Alzheimer's patients not with the targeted medicines, but with the medicines which can alleviate the symptoms. So there were certain molecules which can alleviate the symptoms. But now, in last 1 year, 2 year, there are available FDA-approved targeted monoclonal antibodies against such amyloid plaques, which is the major culprit causing the pathology of Alzheimer's. So, the role of precision medicine is not only to diagnose such neurodegenerative disease like Alzheimer's, but also to treat such early subset of patients so that uh, the progression of the disease can be stopped. Also, we can diagnose many subset of patients who tend to present like Alzheimer's, but they doesn't turn to Alzheimer's. So these precision medicine not only helps to diagnose, but also to rule out Alzheimer's and to diagnose other disease which looks like to be like Alzheimer's. Other than Alzheimer's, definitely there are other degenerative disease where precision medicine comes to play a role, like spinomuscular atrophy, Parkinson's. Again, it's a very common neurological disorder where there are certain genes which play a role in 10 to 15% of cases. There are amyotrophic lateral sclerosis, which we call as a motor neuron disease. So their numbers are endless. But yes, most common which we see is Alzheimer's, where precision medicines definitely do play a role.
Thank you so much, sir. My next question is to Dr. Manish. Sir, how do targeted therapies for multiple sclerosis impact disease progression from symptom management compared to traditional treatments?
Okay, thank you. That's something which is related to my subspecialty. So thanks for asking this, and I'll keep it short because of the short of time. I'm seeing at the watch, in clock in the front of me, and so very quick answer is that we have come a long way. I have told you that we have moved from CNS demyelination. We have now better classified disorders, and all of these disorders are diagnosis of exclusion. That means once you label some person with a disorder with multiple sclerosis, you have ruled out some mimics. Now the job comes how well and how safely you can cater to this. So as Dr. Kunal has already highlighted in one of his deliberations, that you need to look into not only the diagnosis, you have to look into the social background, you have to look into the financial background, you have to look at, and in multiple sclerosis, since it's the disease of young females predominantly, females are involved, 3:1 ratio is there. So you have, and it's the highly productive age group, that means 20 to 40, and it's the second largest leading cause of disability in the world of the young population after just trauma. So you can make out that how important it is to treat this such disorder, because the main target of the treatment you offer this person is to prevent disability. That means giving him a productive quality of life. So once you diagnose, you take all these parameters, then obviously the disease activity is something which guides you. Now we have what Dr. Kunal also said, monoclonal antibodies. That means we now have better understanding of pathophysiology of multiple sclerosis. We have understood that there is role of certain B cells also in multiple sclerosis, and that too in halting basically if you halt the B cell proliferation, then you halt the disease progression also. So not only the number of attacks, which is the usual thing which person comes you with, that I had 2 or 3 clinical attacks in the last 1 year, you also prevent the MRI activity. That means damage which is silently going on inside the body. And there is a slow progression which is independent of that relapse activity also. So you basically address these all. What now we target has changed from just relapse prevention to what we call as no evidence of disease activity. So that is you can understand the heights of the goal which we have set for ourselves. That means we don't have annual relapse rates, we don't have relapses, clinical, we don't have MRI activity, we don't have disease progression over time, and we don't have brain shrinkage. And can you understand a 20-year facing challenge with remembering the phone numbers, doing simple calculation? If they have such problems, they will definitely have problems with there. So if we target this with monoclonal antibodies, targeting the CD20 molecule on the B cells, what we call as the anti-CD20 therapies, now we have which therapies like ocrelizumab, and that's the convenience also. We can't call them or ask them to take a tablet twice a day or oral medication once a day also. It's a 6 monthly regimen. So, and there are medications which are monoclonal antibodies which are there, which can be given monthly. But again, for one day they have to come to the hospital every month. That doesn't make sense. Or previously what the treatment was that you give a shot and 3 days are gone for them because of the flu-like symptoms. Now we have moved on to 6 monthly therapies that they come, get admitted for one day, they take the shot, they go back and forget it. And we have now data for such therapies for safety also for 10 years. So see the change over the time which we have reached, and that is something which we are quite optimistic about as treating clinicians, and we can reflect it on our patients. That's the confidence which we can reflect, and that actually translates into good quality of life. Thank you.
Thank you so much. Thank you, Dr. Kunal, and thank you, Dr. Manish, for an insightful discussion.
During the early stage of the childhood, there are condition called dyslexia. This precision medicine having a genetic analysis can make the life better of the children.
So as you said, dyslexia again is a common disorder which we see in childhood days. So again, usually to treat dyslexia is something, again, it's a multimodality treatment. It's not only a treatment which we as a neurologist we provide. So here the speech therapist also comes to play, occupational therapist also comes to play, definitely pediatric neurologist or adult neurologist comes into play. So one thing is dyslexia per se can be there as a alone standalone symptom also. But yes, it could be a symptom of something underlying genetic problem also, genetic disease also. But for first time when we see such patients, dyslexic child, usually we try to find out the reason for dyslexia. We do certain tests, we try to find out. We try to find out certain abnormality, any structural abnormality where we can find a such symptom, or that dyslexia is progressing, or symptom is static, or it's a regressing symptom. So treatment depends on many things. It's not only the one time we see it's a dyslexia. We also see the progression. We see the other milestones, because dyslexia is a language milestone problem. So we see the motor milestones, not only the language milestone. We see the in context with the other memory problem, whether child is suffering from any memory issues. So dyslexia could be just a standalone symptom and could be a symptom of any structural abnormality. So yes, definitely we should find out the reason for dyslexia. In case if we don't find out any reason, definitely we can go with genetic testing also. There are exome sequencing where we can find out the genetic predisposition of certain disease. But again, as we said in our talks, keeping just diagnosing a genetic disease doesn't always means to treat the patient. So that treatment modality is not per se always decided by the genetic testing. Yes, because it's a multimodality treatment where every aspect comes into role to treat such patients.
Thank you, panelists, for such an engaging discussion. I'd like to thank Dr. Amlani for wonderfully leading this discussion. Now I request Dr. Amlani to co-felicitate her co-panelists. Dr. Manish Mahajan. Dr. Kunal Behrani. Now I request Dr. Manisha Khurana to please felicitate Dr. Anushka Amlani. Dr. Anushka Amlani. I request the panelists to please come to the stage for a group picture.